There are some very interesting phenomena in last part of the nephron here, right? That this part of the nephron is supposed to secrete the potassium, right? And there are special channels in collecting tubular cells, and these are called potassium channels. Again, in these cells, what is happening? Listen carefully. What is happening to these cells, collecting tubular cells, especially principal cells, the special type of cells which are called principal cells? Now, they are operated by aldosterone, right? Normally, how these cells are working, let me tell you how these cells are working. There's the blood. Now, these cells are having on basolateral side which thing? Sodium, potassium, ATPases. They are having sodium, potassium, ATPases. And on the luminal sides, these are having sodium. Yeah, what are these? These are sodium. Don't tell me transporters. These are sodium channels. These are sodium channels. Now look, on this cell, on the luminal side, it is having potassium and sodium channels. And on basolateral side, it has sodium, potassium, ATPases like other cells. Now, these cells are constantly taking the sodium from basolateral side and pushing into cell. Okay, I'm wrong. Let me correct myself. Sodium, potassium, ATPases from basolateral membrane, they are constantly throwing the sodium out of cells. You know, 3 sodium goes out. And they are constantly bringing what in? Potassium in. So it means that these cells, like other nephron cells, are constantly throwing the sodium out, so they become sodium poor, and constantly from basolateral membrane, due to sodium, potassium, ATPases, they are accumulating the potassium, so they become potassium rich. Now listen one thing. They are having both sodium channels as well as calcium channels. Due to this reason, whatever sodium is present here, this will love to go in, so that it can go back to the body. Is that right? And whatever potassium is here, because cell become very rich on potassium and its luminal membrane has channels for potassium, so this potassium will come, yes, into lumen. It means these cells, collecting tubular cells on the luminal side, have capability to reabsorb sodium and capability to secrete potassium. Is that right? Another thing which you really know is that sodium reabsorption is more than potassium leakage. When sodium is constantly moving in, then luminal side of the membrane will become electropositive or electronegative. It should become electronegative. So we can say luminal fluid or luminal side of the last part of the nephron is electronegative, because from here sodium is rapidly going in and usually less amount of potassium is coming here. So, and secondly, sodium is going in but chloride is not going along with it. So naturally anions are left behind but cations are going in. And whatever cations are going in like sodium, some cations like potassium are coming into lumen. But the number of cations which go into cell are more than the number of cations which are coming from the cell. Due to this reason, we can say that luminal side is losing more cations to the cell and gaining less cation from the cell. Number 2, luminal cell is not taking up the anions. Due to this reason, normally this luminal side is electronegative. Am I clear to everyone? Now, I will tell you something very important. We keep on hearing that there are some diuretics. We keep on hearing and discussing and reading that some diuretic waste the potassium and other diuretics spare the potassium. Let's clear this concept forever. That why one group of diuretic are potassium wasters. We call them potassium wasters. And why some group of diuretics are potassium sparing. Let's discuss it. Let's come to the very first drug, acetazolamide, which we were discussing. That acetazolamide was working on this side. It was increasing the load of sodium to distal part. It was increasing the load of bicarb to distal part. It was increasing the load of water to this part. Is that right? So we can say when drug is working here, acetazolamide is working here. So what is really going more display? Extra load of sodium more than the normal. Extra load of, yes, bicarb, right? And extra load of water. You are so intelligent. I was explaining that when you give a person acetazolamide, right? This will react with carbonic anhydrase on the luminal and carbonic anhydrase in the cytosolic area, and it will reduce the sodium reabsorption from proximal convoluted tubule, and it will reduce the bicarb reabsorption from proximal convoluted tubule. What will be the result? The sodium and bicarb load will move forward in distal part of the nephron. Some of the sodium will be reabsorbed from distal part of the nephron, but still some extra sodium will come into collecting tubule. Along with the sodium, a lot of bicarbonate will come. And of course, the sodium and bicarb, they will osmotically pull water with them. So we can say what acetazolamide has done. Acetazolamide has increased the sodium load in last part of nephron. It has increased the anion load, and it has increased the water load. Now these three things will increase the potassium wasting. But how? Cause number one. The extra sodium which come here, some of the sodium will be taken by these cells. If these cells are getting extra sodium, now listen, any diuretic which work proximal to this point and it brings more sodium here, it means these cells are able to take up more sodium. It means they will be pumping out more sodium to basolateral side, to the blood. It means that these sodium potassium ATPases will be bringing in more potassium. So intracellular potassium level will go high. So potassium concentration gradient from the cell to the luminal fluid is now getting higher. So more and more sodium arrives here. More chances the sodium will be taken up by these cells. More their basolateral sodium potassium ATPases will work. Of course, this extra sodium will be reabsorbed, but a lot of potassium will be taken in, and cells become more rich in potassium. And cells, these are principal cells in the collecting tubules, when they become really extra rich in potassium, right, what really happens, that movement of potassium under the concentration gradient from the cell to the lumen will be normal or more than normal? More than normal. So number one, these cells will be secreting extra potassium, so this will lead to excessive loss of potassium. We call it kaliuresis. Excessive loss of potassium. This is mechanism number one. Mechanism number two is these anions, bicarbonates. If any diuretic, please listen carefully, any diuretic which work proximal to this point and increases anion load in this area, anion may be bicarbonate or it may be chloride. In this particular example, it is bicarbonate. If bicarb load in this area is increased, it means when bicarb are going down, they will attract cations from the cells. Because when extra bicarb come over here or extra anion come over here, the lumen will become more electronegative. And when lumen will become more electronegative, it's very natural that cations from within the cell will jump out. And which cations are jumping out? From the cell into lumen? Potassium. So whenever any diuretic which work proximal to this point and load more and more anion to this area, in this particular acetazolamide example, bicarbonate is being loaded in this area, but in some other diuretic we'll talk about later, the chloride is loaded in this area. So bicarb or chloride, whatever anion is overloaded in this area, this makes the membrane luminal side extra electronegative. When this area becomes too much electronegative, what really happens? What really happens when it becomes too much electronegative? The result will be that this electronegativity in the lumen will attract more potassium from the cell to this, and this is the second reason that potassium loss will be increased. Third reason is very simple but very important. Any diuretic which is working proximal to this point, that will increase water load also in this area. And if water load in this area increases, it means if there's more water reaching here, more than normal amount of water which is reaching here, it means flow here will be slow or fast. Luminal flow
will be
fast. Look, all the diuretic which work proximal to this, they bring more sodium here. Some of them bring more anions here, and of course they also bring more water here. And when more water is coming on the last part of the collecting tubule, in the collecting tubule rather, what really happens? When more water is coming here, the luminal flow will become slow or fast? It will become fast. And when luminal flow will become fast, it means potassium will be washed away gradually or rapidly. And if potassium is washed away from this side towards the last part of nephron very rapidly, then potassium concentration in the lumen become very low. So concentration gradient for the potassium from the cell to the lumen will become again very high, and excessive potassium will be lost from the cell to the lumen. So it means that further chelidioresis. Now let me recap what I was saying. I was trying to give you a very important concept, that all the diuretics, listen carefully, all the diuretics which work proximal to the collecting tubules, and they are bringing more sodium into this area, or they are bringing more anion to this area, or they are bringing more water to this area, they are going to lead to heavy potassium losses from the body, right? Again, if more sodium is coming here, the sodium will be exchanged for the potassium. If anions are coming here more, they will attract the potassium which is cationic into lumen. Or if more water is coming here, then potassium concentration in this area will drop as potassium is being washed away, and more potassium from the cell will spill into tubular fluid. So as a rule, we can say the diuretics which work proximal to this point on the nephron, all of those diuretics are potassium wasters. All of them are potassium wasters. And how the potassium sparing drugs work, we'll talk later in the lecture. Now we'll be talking about basically that how this thick ascending part of the loop of Henle handles the sodium and different anions and water, and how the drugs or diuretics work on this part and alter the fluid electrolyte balance in the blood as well as in the urine. But before we really concentrate on that, I want to highlight a very important point. The very important point which I want to highlight before really I go into detail is that some part of the nephrons are freely permeable and to water and others are not. Let's look at whole diagram, and we'll see it that this is which part of the nephron? Proximal convoluted tubule and descending loop of Henle. This is proximal convoluted tubule, and here it is descending loop of Henle DLH, right? And here is hairpin turn, and then this is thin part of ascending, yes, loop of Henle, and this is thick part of ascending limb of loop of Henle. Now, the point which I want to highlight, that first of all, as good doctors, you must be very clear that which part of the nephron has what type of permeability to the water. Now, this young lady is going to tell us that water permeability in this part, yes, water permeability to this part is regulated by which substance? Yes, please. Yes. You have to tell me that which substance regulates the water permeability along this proximal convoluted tubule and descending loop of Henle. Yes, please. Do you know any substance or any factor which alters the water permeability? You should not know, because no one knows. The point which I want you to remember is that this part of the nephron is under all circumstances freely permeable to water, Remember, even though in the books we read that there are tight junctions in between the cells, they are tightly holding the cell together, but they are water leaky. So we can say this part of the nephron is always leaky to water, or always freely permeable to water. What is its implication? What's the fun in knowing this point? The fun in knowing this point is that when water comes here, when filtrate come here, right, its osmolality is the same as blood. Blood has a osmolality of about 280, or you can say 300 milliosmol per liter. Milliosmol per liter. When filtrate come here, again it has osmolality of 300 milliosmoles per liter. As fluid is going down, you know there's uptake of all the glucose from this area is reabsorbed. All the amino acids are reabsorbed by proximal convoluted tubule. About 65% of the sodium is reabsorbed. Some sodium here is reabsorbed as a counter transport with protons. Some sodium is reabsorbed with glucose. Some sodium is reabsorbed along with chloride. Some sodium is reabsorbed with bicarb. Some sodium is reabsorbed with phosphates. Some sodium is reabsorbed with amino acids. So what really happens? That as water is going down, lot of solutes are being reabsorbed. So a lot of solutes are moving from luminal side to the intracellular side to the pericellular area or outside the cell. If a lot of solutes are moving like this from the lumen to the cell, from the cell to interstitial fluid to the capillary, if solutes are being pumped or transported in this direction, and if this part of the nephron is very, very permeable to water, then water will follow. You know, solutes drag the water. So what really happens? When solutes are moving, water is moving with the same ratio. And by the time the fluid, for example, here it was 100 ml fluid, by the time fluid reaches here, it is left only 35 ml per minute. Is that right? So it means about 65% of solutes and water are reabsorbed. And do you think what will happen to water by the time water from here to here it reaches, or luminal, you can say fluid as it is going down, and it is exiting from the proximal convoluted tubular system and entering into loop of Henle, then its osmolality, which was at entry point 300 milliosmol, what will happen to its osmolality? It will get this fluid as it is going down, it will get diluted or it will get concentrated. Yeah, it is going to get concentrated. Again, young lady, there is a question. Let's suppose you make some juice, is that right? And out of that juice, you have 3 glasses of juice in a jug. You remove the 2 glasses of juice. What will happen to the rest of the juice? It get concentrated or diluted? It will be the same. Same thing happen here. This is what I'm trying to tell, that from here solutes are going along with the water. Water is allowed to freely follow the solute. This part of the nephron is always permeable to water. That is why water always follows it. So as solutes are moving, it should get actually diluted. If from a material, if you're removing the, from a, you can say solution, if you're removing the solutes, the remaining solution should become diluted. But if along the solute, solvent is also following, and both are following in the same ratio, do you think they will get concentrated or diluted? Not at all. So what really happens, amount of fluid here and amount of fluid here is very different. But osmolality of fluid here and here is the same. And we say absorption of the solutes and water from the proximal convoluted tubule is isotonic, because on the way fluid does not become hypertonic and does not become hypertonic. Am I clear? Now, let me tell you a very simple thing. This part of the nephron, proximal convoluted tubule, until, what is this? Descending part. Up to this point, nephron is freely permeable to water under all circumstances. Then we start going up. As it is going up, nephron become absolutely water impermeable, and under all circumstances it remains water impermeable. What does it mean? That if I draw a mini nephron here, okay, just for your understanding, here's a mini nephron. Look, this part is always allowing the water free movement. freely permeable to water movement. Right? What is this part of the nephron? Proximal convoluted tubule and descending part of descending loop of Henle. And this part is always water impermeable, whatever you do. It means this part, descending part, will allow the solute to move and let the water to move with them. Right? But this part will allow the solute to move but never allow the water to follow. It means in this part solute will move out, but water will never move out with that. It means as tubular fluid will go upward, it loses the solutes on both sides, but it does not lose its water. So progressively it becomes diluted. So what we really say that the fluid which enter here is osmolality is 300 milliosmol. When it reaches, as it is coming down, it up to proximal convoluted tubule, it remain same. Isotonic absorption is there. But really what happens, look here, when fluid is going upward, right, solutes are thrown out, but water is not allowed to follow because this part is permanently water sealed. It is the waterproof part of the nephron. It is the waterproof part of the nephron. So as luminal fluid goes at this point, it will be highly diluted. So we say this segment is a diluting segment. Am I clear? After this, when fluid will move forward, if there is no ADH, if there is no antidiuretic hormone, this part will always remain water impermeable. But if there is ADH, then this part of the nephron will become water permeable. It means, listen carefully. So it means when it is, look, when fluid is descending into nephron, right, in proximal convoluted tubule and which one? Descending limb of loop of Henle. When fluid is descending down, water can move along the solutes. Is that right? But as fluid start going up through ascending limb of loop of Henle and thick part, solutes are allowed to move out, but this is always water impermeable part. And last part of the nephron, its water permeability depends on the presence or absence of ADH. If ADH is not there, it remains water impermeable. And if ADH is there, then this area will become water permeable. Later on I will explain that as you move down in this diagram, osmolality keep on increasing. Osmolality from, this part is in the cortex and this is in medulla. In medulla there is hyper osmolality. In medulla, as you go down into medullary interstitium, from cortical side to medullary interstitium, osmolality increases. Right? Now, it means that this tube, which is initial descending part, it moves from less osmotic interstitium to hyperosmotic interstitium to medulla. So when nephron moves from cortical area to interstitial part of medulla, then what happens? Interstitial fluid become progressively more and more, yes, concentrated. Interstitial fluid become more and more concentrated. And when this goes up from highly concentrated area, it is going to less concentrated interstitium. When it turns back again from less concentration, it is going to high concentration. Let me explain. Osmolality here, osmolality scale I am making. Osmolality in the cortical area is 300. As you come down, it becomes 600. You come further down, it becomes 900 milliosmol. Then it becomes 1200, and in some circumstances it becomes 1400 milliosmol per liter. It means as you move from cortex to medulla, interstitium is becoming more and more hyperosmolar. And as you move from here, what is this? From medulla to cortex, it becomes less and less osmolar. And again in the last part, again when it dip into medulla, from the cortex to medulla, collecting system, again it is dipping into highly osmolar what? Interstitium. Am I clear? Now listen, what's the importance of knowing this thing? I've explained two things. Number one, from cortex to medulla, interstitium become more and more, progressively more and more osmolar. Number one. Number two, another point which I want to, we have to concentrate on this part, please. Right? Now, another part which I want to concentrate, that this part of the nephron, proximal convoluted tubule and descending limb, it is freely permeable to water under all circumstances. Then ascending part is, and early part of distal convoluted tubule is always water impermeable, and last part is water permeable if there is ADH, and it is water impermeable if there is no ADH. Now let's make one more concept. What is that? Look, as fluid is coming down, right, we can make now diagram here. If here osmolality is 300, here it is suppose 600, here it become 900, it become 1200, and sometimes it become 1400. Now what we really see that, now let's come to the main diagram, and what we will see, we'll focus on the whole diagram. What we really see that from the right fluid here was having fluid which is in the luminal area, it has the same osmolality which was outside interstitium. But as this reaches here, descending limb is going into what? Hyperosmolar area, hyperosmolar interstitium. So it means that osmolality or solutes are more outside and less inside. So this part of the nephron will lose water, right? Now listen carefully. It will lose the water, but it will not lose much solutes. So what really happens? Compare early part of descending system and then late part. In proximal convoluted tubule, whatever solutes are absorbed in the same ratio, water is absorbed. So within the lumen, osmolality remain same. But when we come to this part descending, the fluid which enters here, it has osmolality of 300, right? And outside osmolality is getting more and more hyperosmolar. So it means that luminal fluid is become as compared to the outer fluid is far less osmolar. So what really happens? Water start going to from hypotonic area to hypertonic area. So water start moving out of descending limb of loop of Henle, and some solutes start jumping in, right? So what really happens? What really happens that by the time water is gradually, tubular fluid is gradually going down, tubular fluid is losing the water and gaining the solute because its membrane is freely permeable to solutes and water. So by the time fluid come here, its concentration is also same as outside because it is equilibrated. So it means that when fluid is going from Bowman capsule up to the end of proximal convoluted tubule, there is isotonic absorption of solutes and the fluid. But as it moves in the initial part of descending limb of the loop of Henle, because it is surrounded by hyperosmotic interstitium, so progressively it loses the water and progressively it gain the solutes. So by the time fluid reaches hairpin turn, it becomes hyperosmotic. But as soon as this fluid start going up, as soon as this hyperosmotic fluid from the which area? What is this area? Hairpin turn. As soon as this fluid start going up, the walls become water proof, impermeable. They become absolutely water impermeable. Because these walls become totally water impermeable, now fluid, highly concentrated fluid is going up. Is that right? Then what happens? I will explain. These cells throw actively solutes, but they don't allow the water to go to interstitium. So as fluid in the luminal area is going up, right, into thick part of ascending limb of loop of Henle, it is progressively losing solutes, but it's not losing water. So what really happens? These solutes which are constantly coming here, they will make this area hyperosmotic. They are responsible to make this area hyperosmotic because this part of the nephron can throw solutes very actively out, right, into interstitium, but they don't allow the water to follow, and they are responsible to keep the medullary interstitium hyperosmotic. But by the time fluid reaches here, it has lost a lot of solutes out, so fluid will become hypotonic, or it will become diluted or concentrated, and once it becomes diluted, it may become only 60 milliosmoles. Now look, under all circumstances, this part of the nephron is water impermeable under all circumstances, right? Under physiological circumstances, it is throwing constantly solutes out. So it means this part is responsible to dilute the luminal fluid, and this part is responsible to make hyperconcentration in interstitium, right? Some people refer this part of the nephron as diluting segment. They call it diluting segment. Now listen carefully. If you have diluted the urine, and if there is no ADH, this part of the nephron will remain water impermeable, and diluted urine will keep on going forward without losing any water. So person will pass what type of urine? Highly diluted urine. But let's suppose if your ADH level is high and you don't want to lose the water, then ADH hormone will alter these cells. When ADH hormone will alter these cells will become water permeable. And once these cells become highly water permeable, then from here highly diluted fluid is going down. Is that right? But as highly diluted fluid is going down, if this area was impermeable, right? Even though this part of the nephron is progressively going to medullary interstitium and dipping into more and more hyperconcentrated interstitium, but if there were no ADH and it is highly impermeable, then diluted fluid will be passed out as diluted urine. But if this part become highly permeable to water due to presence of ADH, then what will happen? The hyperosmolality which is present over here, it will pull the fluid, water outside, because it is now water leaky. Now hyperosmolality of this area will pull the fluid to interstitium, and as fluid is moving out into interstitium, urine is getting concentrated. So really, what determines will pass diluted urine or concentrated urine is the presence of ADH over here. Is that right? Again, let me repeat the whole story. Okay, you would like to understand in the small diagram or large diagram? Hurry up. Large diagram. Look, it's mother diagram, that is daughter diagram. I think granddaughter diagram. Now listen again. Under all circumstances, this part of the nephron is water permeable. All physiological circumstances. Under all physiological circumstances, this part of the nephron is water tight. This is water leaky. This is water tight. And this area will be water tight or water leaky. It depends on ADH is there or not. Am I right? So, when fluid is another thing. This part is constantly throwing solute out. So, it is making the medullary interstitium highly concentrated. And some urea is also cycling from here to make it highly concentrated. Now, as filtrate is formed, it is isotonic with the blood. In this part, right, proximal capacity, solutes and water are absorbed in the same ratio. So, fluid remain isotonic. But even though this area is fully permeable to water, as well as this is fully permeable to solutes. So what really happens, as this fluid is going down, right, it is going into interstitium. This tube is, you can say, progressively entering into interstitium, which is hyperosmotic. So it will keep on losing water, keep on gaining solute. So by the time tubular fluid reaches here pin turn, it is highly concentrated, and then it starts turning upward. Now it is moving from medulla to cortex, right? And when it is moving upward, suddenly the cells become impermeable to water, but they keep on throwing the solute out. So we say, as this fluid is moving through the thick part of ascending limbo loop of Henle and early part of distal convoluted tubule, the tubular fluid become progressively diluted. So we call this also diluting segment. So everyone makes the urine tubular fluid highly diluted up to this point. After that, what determines that urine which you are passing, it will be diluted or concentrated? This factor will be controlled by ADH. This is the ADH which is released by the posterior pituitary gland, and the osmoreceptors in hypothalamus which determine the osmolality of the blood. If blood is hyperosmolar, osmoreceptors will give order to release ADH, and ADH will come and make these cells highly permeable to water. So when this will dip into progressively more and more hyperosmolar interstitium, hyperosmolality will pull the water out of luminal area, and what really happens, the urine passes highly concentrated. If blood is hyperconcentrated, urine will be also hyperconcentrated. If blood has a little increase in osmolality, urine will become highly concentrated, so that water should be conserved in the body. But let's suppose if you take 10 glasses of water, you are trying to little bit reducing the osmolality of the blood. Blood osmolality go little down. Osmoreceptors inhibit the production of release of ADH. Your ADH become less. What really happens? The last part of the nephron becomes water impermeable, and then whatever diluting urine you are making up to this point, right, hyperosmolality cannot pull this water out, and you will pass lot of water, right, with dilution or with hypotonic urine, or we can say that urine will be totally dilute urine passage. Is that clear to everyone? Now we will be discussing a very special function which is performed by the cells in the thick part of ascending limb of loop of Henle. As you know, like all other cells in the nephron, these cells also have on the basolateral side sodium potassium ATPases, right? This is something present in all nephron cells, and as you know that these sodium potassium ATPases are actively transporting sodium out of the cell and pumping the potassium into cells. For every 3 sodium it pumps 2 sodium N, potassium N, 2 potassium N. So in the end, cell become poor in sodium and cell becomes relatively rich in potassium. Right? Now this is same which happens in every cell in the nephron. All cells are throwing sodium out of the cell on the basolateral side and accumulating potassium. But there is something very special which happens on the luminal side. On the luminal side, there is a very unique type of transporters, right? There is a very unique type of transporter, and what is the uniqueness about it? The uniqueness about this transporter is that this transporter actually transport 2 cations in along with 2 anions. Now cations which it transports in is sodium, and along with the sodium it throws in potassium, and along with that it takes up 2 chloride, not 1 but 2 chloride. That is why this is called, the name of this particular transporter protein, which is integral protein in the luminal membrane of the thick part of ascending limb of loop of Henle. This is called sodium potassium 2 chloride. Look, this should be called sodium potassium 2 chloride transporters. 2 chloride transporters. So we should call them sodium potassium 2 chloride transporters. Let's put this thing, please focus here, that we will make this here as a in our key. Right, it is sodium potassium 2 chloride co-transporter. Now, this is a very unique type of protein. This is very unique type of protein which is expressed on the luminal side of the ascending limb of loop of Henle, and to some extent in early part of the distal convoluted tubule. What is the function of this? It is taking up cations from the luminal fluid as well as anions from the luminal fluid. So it is taking positively charged and negatively charged solutes and concentrating them into the cell. Is that right? But the cell does not allow the water to move. Does this allow the water? So all these cells which are present on this side, due to the presence of sodium potassium 2 chloride proteins or co-transporters, or we call it symporters, they are constantly taking sodium, potassium and 2 chloride from the luminal fluid to the cell. Now whatever sodium comes in, right, this will go out of the cell due to the presence of, yes, sodium potassium ATPases. So there is no problem. The sodium will be eventually coming out, and this sodium will add to the hyperosmolality of interstitium, right? What about chloride? Chloride also has special transport mechanisms on the basolateral membrane, so this chloride will also go out. So we can say that these cells are constantly taking sodium and chloride from the luminal side, right? And through the cell, eventually they are thrown into interstitium through the basolateral membrane. When sodium and potassium, sodium and chloride come into this side, naturally it will contribute to the hyperosmolality in interstitium. But there's a very special remarks we should make about potassium. Potassium is a funny thing. That something is happening very strange here. The potassium is being pumped from the basolateral membrane into the cell, and it is also being transported from the luminal side into the cell. So cell become progressively very, very rich in potassium. Cell is becoming very, very rich in potassium. Now, when so much potassium will accumulate into cell, then naturally we should have some escape mechanism for it. You will be surprised. Nature has provided us special type of potassium leaky channels on the luminal side. So potassium which has gone from here in, the potassium which has gone from here in, it will recycle and escape out. So what really happens? That these sodium potassium 2 chlorides are constantly taking sodium potassium and 2 chloride molecule ions from the luminal side to cell. Sodium and chloride will escape out, but potassium is accumulated into cell. Not only from the luminal side, but sodium potassium ATPases from basolateral side are also pumping the potassium into cell. When cell become very high into potassium, potassium escapes on the luminal side through potassium channels, and because this area becomes rich in potassium, so this will become electropositive or electronegative? Electropositive. So we say this part of the nephron on the luminal side is electropositive. This part is electropositive. Now you may be thinking, what's the fun in knowing that it is electropositive or negative? What is its importance? Let me tell you something very important. Actually, when potassium again and again comes out, potassium becomes very rich in this area. When it becomes positively charged, then any other divalent cations, please concentrate here, that what really happens, that sodium was coming from here, sodium was coming from here, potassium was coming from here, chloride was coming from here. We have learned that sodium and chloride have gone to this side. Potassium has recycled back. And this potassium is responsible to keep this area electropositive. This is keeping this part of the luminal membrane side electropositive. But not only these things are coming, but lot of calcium and magnesium is also coming here. Calcium and magnesium are called divalent cations. They are called divalent cations. Now imagine when calcium and magnesium, they enter into this part of the lumen and they find that wall of the lumen everywhere is electropositive. When they find this is electropositive, you know that positive repel positive. So because potassium is forcefully coming out, can calcium and magnesium stay into this fluid? No. So they escape through gaps in between the cells. So when this calcium and magnesium rush out through the gap, you can say junction present in between the cell, we say they are not going through the cell, they are going in between the cell. Or we can say calcium and magnesium are reabsorbed not through the cell, they are reabsorbed from the side of the cell. So those substances which pass through the cells, we say they are going through transcellular transport. That is called transcellular transport. But calcium and magnesium has gone in between the cell or from the sides of the cell, so we say their absorption is paracellular transport. So what did we learn here? We have learned sodium, potassium and chloride, they are going through, especially sodium and chloride, in this part of the nephron is reabsorbed through transcellular route. But because potassium leaks back, recycles, right, this potassium makes the membrane of this luminal side electropositive. And this electropositivity, due to the abundant presence of potassium, makes the you can say it repels calcium and magnesium. So when calcium and magnesium through the tubular fluid reaches here, it finds that luminal surface of the tube is electropositive. So they escape out of the luminal area to the interstitial area through the, yes, through the paracellular route. Am I clear? Is it clear to you? Now we'll concentrate on one more thing. And what is that? We'll talk about that if we apply a drug which really blocks this system. If we apply a drug which will block sodium potassium 2 chloride, what really happens to the whole dynamics of urine formation and other changes in the body? Now, do you know the drug which can block this? The drug which can block here, there is a drug, that drug is partly filtered from here, partly it is actively transported. And this drug will come along the lumen. And along the lumen, this drug will reach here. Again, let me repeat it, that the drug, for example, that drug we have taken parenterally or we have taken orally. Once it comes into your circulation, it will go to the renal system. Part of it is filtered, but a lot of it is actively transported by the proximal convoluted tubule and secreted into lumen. This drug will be moving along the nephron, and when it reaches here, it will find sodium potassium 2 chloride, and this drug loves the sodium potassium 2 chloride. So what will happen? This will hug the sodium potassium 2 chloride, and this drug will, when capture sodium potassium 2 chloride, what really happens, I'm going to explain. Right? This is the drug. And it has captured, yes. What is the name of this drug? This is a very special drug, and it is sticking to the sodium potassium 2 chloride, especially with that domain we take the chloride in. And once this drug sticks with it, once this drug sticks with this, what really happens, that now, yes, you have to tell me, now what will happen, that when sodium potassium chloride has this drug attached with itself, the sodium potassium 2 chloride cannot transport the, it becomes non-functional. When sodium potassium 2 chloride becomes non-functional due to the presence of this drug, right, there will be changes. But first, what will be the changes? Before we really discuss, I would love to know that what is the name of this drug. Yes, please. Yes, please. What is the name of this drug? Yes, please. Furosemide. This is a whole loop diuretics. It may be furosemide, it may be torsemide, it may be bumetanide, or it may be ethacrenic acid. Right? All these substances basically make the sodium potassium 2 chloride dysfunctional on the luminal membrane of the cells which are present on thick part of ascending limb of loop of Henle. So this is how furosemide work, or loop diuretics work, right? Now when loop diuretics work over here, right, what really happens? They make this non-functional. Now what will be the result? Listen. Result will be there that sodium cannot come in, potassium cannot come in. Is that right? And chloride cannot come in. End result will be this part of the nephron is unable to take up the solutes, cations and anions. So sodium and chloride are not transported from this area to the interstitium. Sodium chloride will move forward. So in the presence of this drug, the amount of sodium and chloride which is going to more distal part of the nephron is less or more? More. Is that right? Sodium chloride load is going to the more distal part of the nephron. Am I clear? This is one thing. Second problem is there, that once sodium and chloride are not allowed to absorb from here, it means they are not coming to interstitium. Interstitium will become less hyperosmotic. Interstitium will become less hyperosmotic, and even urine will become less dilute. Urine will become less dilute. Now, when sodium chloride will reach over here, what will be the result? As you know from previous discussion, that a lot of sodium which is going down, some of it will be extra sodium which come here. This extra sodium will be transported to principal cells of collecting tubular system. Now, as you know, these cells, like other cells, are also sodium poor. Normally what happens? About 60 to 65% of the sodium is reabsorbed from this part, and about 25% of sodium is reabsorbed from this part. About 8 to 10% sodium is reabsorbed from this part, and only 2 to 3% sodium is, very little sodium is reabsorbed from this part. So it means that 25% of the sodium is reabsorbed from here, sodium and chloride. If we apply a drug over here, it will allow lot of sodium and chloride to move forward. And this lot of sodium and chloride, when it will move forward, more distal part of the nephron cannot really recapture it, because more distal part of the nephrons cannot recapture it. So lot of it really appears into urine, and there's a lot of sodium and chloride which is going into urine, dragging the water along with it, and they will produce mild diuresis or heavy diuresis. They will produce heavy diuresis and heavy natriuresis. But as a lot of sodium is going forward, some of the sodium will be taken up by these cells, and when this sodium is going in, this sodium will go out through sodium potassium ATPases. When this sodium will go out through sodium potassium ATPases, of course they will bring in more potassium, and when they will bring in more potassium, then potassium leakage from the cell to the luminal side will increase. So it means that sodium which is reaching here, it is getting exchanged with the potassium. So it means not only it produces natriuresis, but it also produces cheliuresis. It will also lead to the potassium losses, as we discussed in previous lecture. One more thing which I would like to highlight, that this sodium which is going down, right, it has dragged the water with it, and of course because it is electronegative, chloride is also coming here. The chloride which is coming here, this is making this area more electronegative. As I told you, this part of the nephron was electropositive, this part of the nephron is normally electronegative. I will explain later why. And when chloride come over here, it becomes more electronegative, and enhanced electronegativity in the lumen further enhances the escape of potassium from the cell to lumen, and cheliuresis is further increased. So cheliuresis is due to exchange of sodium from the principal cell. Cheliuresis is because anion load on the luminal side of principal cell is increased, and anions attract the potassium from the cell to lumen. Is that right? Another point which I want to highlight, attention please. I said when furosemide is biting on this and inhibiting this, sodium will not be reabsorbed. What else will not be reabsorbed? Chloride will not be reabsorbed. If sodium and chloride is not reabsorbed, they will be going distally. Number one, that will result in natriuresis. Number two, sodium exchange in the principal cell will bring in more cheliuresis, and anion present here attract the positive cations from the cell, again cheliuresis. But we did not discuss an extremely important point. The extremely important point was that when this drug is applied here, not only sodium and chloride are not reabsorbed, actually potassium is also not reabsorbed, because it was sodium potassium 2 chloride transporter. So when this transporter fail, not only these cells fail to take up the sodium, and not only they fail to take up chloride, they also fail to take up potassium. When potassium is not going in, it means intracellular potassium levels go down. It means potassium which is leaking to the lumen will be more or less? Less. It means when you apply the furosemide here, potassium cycling from the lumen to the cell is less. It means from the cell, recycling to the lumen is also less. So what really happens? The electropositivity which is present here will decrease, and this area will become less electropositive. Please listen carefully. When this area will become less electropositive, what will happen? It will no more, you can say, push the calcium and magnesium or other divalent cations to escape through the paracellular route. Do you think if because it was the potassium recycling generated electropositivity which was forcing the divalent cation to escape through paracellular route? When furosemide is applied to sodium potassium ATPases, it is applied to sodium potassium 2 chloride system, not only sodium and chloride uptake is failing, but potassium uptake is also failing. When cells become poor in potassium, they are not leading to recycling of potassium to the lumen, and electropositivity on the lumen become less. And when electropositivity on the lumen become less, then calcium and magnesium are no more pushed through the paracellular route. So we can say reabsorption of calcium and magnesium through the paracellular route is decreased due to decreased electropositivity on the lumen, which is due to decreased potassium recycling, which is in fact due to decreased activity of sodium potassium 2 chloride transporter, which is actually due to application of loop diuretics. Now, if this part is not reabsorbing calcium and magnesium, the load of calcium and magnesium will go to distal part. Calcium will come over here in extra amount and magnesium as well. Is that right? Even though there is some parathyroid controlled calcium reabsorption in distal part of the nephron, but some calcium will be lost. So it means that there will be not only natriuresis, not only kaliuresis, but there may be calciuria and magnesuria. Is that right? So if someone is taking furosemide for long-term base, an old woman taking furosemide for a long time, what really happens? That excessive calcium losses are present in the urine for years and years, and even this little loss of calcium may eventually activate the parathyroid hormone to activate certain osteoclasts in the bones to release the calcium from the bone, and women may develop more accelerated osteoporosis. Is that right? This is one side effect. The loop diuretics loop out the calcium. Is that right? This is one point which is very important to know. And second point which is very important to know regarding this thing is that this has one therapeutic application as well. For example, if you have a patient who has severe hypercalcemia, one way to manage this patient is give intravenous furosemides. When a patient has severe hypercalcemia, you give him intravenous furosemide, then whatever calcium is filtered, right, the part of the calcium which was supposed to reabsorb from thick part of ascending limb or loop of Henle will not be reabsorbed, and you will produce heavy calciuria, so body will get rid of calcium. But remember one thing, that under these circumstances, person is not only losing the calcium after parenteral furosemide, he is losing sodium and chloride, and of course everything is dragging the water. So very rapidly person will become dehydrated. So, but if person is losing the calcium as well as water, calcium concentration in the blood will not change. Rather, we are putting the person to the dangers of dehydration. That is why such type of management, when we are giving furosemide to get rid of the calcium out of the body, we must give normal saline in abundant amount, carefully of course, along with the furosemide. So, the one of the management of hypercalcemia when calcium level in the blood is very high is give the parenteral furosemide along with normal saline, so that when the diuresis, natriuresis, kaliuresis and calciuresis start, person should not become dehydrated. Is that right? One more point which I would like to highlight is that when sodium is going more distally, if you are using furosemide for a longer time, what really happens? You will become dehydrated. Okay, we'll discuss that later. One more point which I want to highlight about these cells. These cells, some cells which are present over here, these are called intercalated cells. In collecting tubule, these cells are called, this was principal cell and this is intercalated cell. Intercalated cells have a master function and regulation of acid-base balance in a special way. How? Actually, intercalated cells also have carbonic anhydrase and they have a capability. Please focus here that intercalated cells also has carbon dioxide and water, and they have a very special type of, what is this? You remember your friend? Carbonic anhydrase, and they are capable of making what? Carbonic acid, right? And this carbonic acid dissociate into bicarb and protons, and these protons are there are special proton active transporter on the luminal side, and they are actively transporting these protons from the cell to the lumen. Is that right? They are bringing lot of proton from the cell into lumen. So it means this part of the nephron, by the virtue of presence of intercalated cell, is constantly secreting protons. And of course, during this process, it is making what thing? It is also making bicarb. And this bicarb is pumped to the blood. So it means intercalated cell provide the acid to lumen and provide the alkali to the body. Is that right? This alkali will react with the fixed acid in the body, right? And the proton will come here. And this proton, as you know, will react with phosphates. This proton usually react with HPO4 and make it H2PO4. Or this proton will react with NH3 and make it NH4 with chloride. And it means when protons are secreted more over here, extra protons are coming here, then in the urine, HPO4 concentration will go up and NH4Cl concentration will go up. It means urine will become more acidic. Urine will become more acidic. Having said all of this, now correlate this information with the furosemide. Actually, listen carefully. All the diuretics which bring more sodium over here, attention please, more sodium will move into cell. This area will become more electronegative, and more electronegativity will pull more potassium from the principal cell to the lumen, and it will pull more hydrogen from the intercalated cell into this area. So it means that when you're putting furosemide here, more protons are going to urine. It means urine is also getting more acidic. Or another way, if more protons are going over there, is that right? What really happens? More alkali is going over there. Is that right? Just hold on. Again, let me repeat it.